Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. It is now my pleasure to turn this conference over to Chris Hunt. Chris, you may begin.
Thanks, Chantel. Hi, everybody. Good morning or good afternoon to you, depending on where you are. Welcome to the April National webinar for the TeamSTEPPS National Implementation Project. Thanks for coming. Today's topic is TeamSTEPPS for Code Blue teams, piloting SBAR and CUS for interprofessional team education. So we'll really get into a couple of specific tools today and talk about their specific uses with our speakers. Just a few things that I want to talk about before we get started. First off, some rules of engagement. The audio for this webinar can be accessed in two ways. So you might be listening through your phone. If you've dialed in a number to listen here, make sure you mute your computer speakers. And you can do that. There's a little speaker at the top of your screen you're looking at right now. If you click on it, you'll mute the speakers. You want to do this because otherwise you'll get all kinds of weird feedback issues, kind of like calling into a radio station and listening to yourself. So you want to do that. You can also listen just through your computer, and it looks like the majority of you are doing that. Just, of course, a note about that then. If you ever have any questions, verbal questions, a technical issue that you're trying to ask about too, you wouldn't be able to do that. So you'll want to use that chat function that you see on the right-hand side of your screen. And using that chat function is actually the way that we like you to ask questions, generally anyways. Throughout the course of this, please feel free to chat in questions. If you have a logistical issue, if you're having a technical issue, that's the quickest way to get it fixed, if you chat that in there. Also, we try to encourage people to chat questions into that box that they might have about the content. The reason we do this is because this lets us get the most number of questions answered at the end. It also allows us to try to order the questions in some sort of coherent fashion so that the Q&A seems to hit as many topics as possible and they make sense sequentially. If you don't get your question answered, if we run out of time, we do have the opportunity to ask these questions afterwards of the speakers, and they'll come up with an answer, and we'll post those answers on the TeamSTEPPS portal website that we'll talk about in a little bit. So definitely lots of ways to get your questions answered. If for some reason we don't get a lot of chatted-in questions, and we still have time at the end, then we might open the lines for audio questions for those folks that are on the phone. But that's often not something likely that happens. A few acknowledgements real quickly before we start. This project is sponsored by the Agency for Healthcare Research and Quality. AHRQ is from the Department of Health and Human Services, and Jim Battles is our main project lead there. And AHRQ, as well as Heidi King in the Department of Defense, have really been integral in the TeamSTEPPS work before there even was TeamSTEPPS. Back some time ago, around 8 years ago, TeamSTEPPS was launched nationally for the civilian and military worlds, and we're really thankful for the continued support of that because it allows these webinars and our trainings and everything that we do to be free to everyone. My name is Chris Hunt, and I actually am the project team lead the project team here at the Health Research and Educational Trust. And what I'm able to do by leading this team is make sure that we get good content out to everybody, make sure that we get trainings out to everybody, and that we have a national conference every year. So very thankful to AHRQ to be able to do this for everybody through HRET. So we do offer master training courses every year. These are 2-day training courses, and in it we do a train-the-trainer approach. So if you have the ability to attend one of our courses, these serve as a way not only to teach you about TeamSTEPPS, but teach you how to go back and implement TeamSTEPPS. So we not only make them into a learning experience, but we hope that it's a quality improvement course as well that puts you on a track to solving a specific problem in your organization. So I think that they're really great courses, and if you have a chance to attend, they're really well done. Speakers today that you're going to be meeting soon are actually from one of our regional training centers from UCLA in Los Angeles. Some upcoming TeamSTEPPS events, we have monthly webinars that are scheduled through September 2015. You can register now, actually, for next month's webinar, which you see the topic there, also about a specific tool, kind of like these are today. Master training courses I've spoken of, and those go through August of 2015. If you can't travel, don't have the funding, or if it's just difficult to do so, there's also online courses. TeamSTEPPS 2.0 online master training courses are available at the web address you see there. And these are also really great courses that take you through everything that you do in the in-person course. So if that's something that seems like a good option for you, please head on over and enroll at the course there. We have a national conference coming up that is in Denver, Colorado, June 16th through 18th. Conference is free, which can't beat that. The conference is a mixture of traditional panels discussing things and a lot of workshops, too. I think that we have around 8 workshops this year, very interactive, learning about all different types of topics, coaching, simulation, some other things. And so if you're interested, if you can get to Denver, it's a great networking event as well. We have a lot of opportunities for people to get together and talk, and it's entirely driven by the TeamSTEPPS community. Everybody has sent in proposals for their presentations, so we're really looking at a good group of dedicated people who are interested in TeamSTEPPS. It's not something just put together by the project team. So I think it's a great experience every year. All these events you can learn about by going to teamsteppsportal.org. That's actually where you went to learn about this webinar, so just head on over there. If you need any help ever, there's a helpline, phone number 312-422-2609, or you could email us at arcteamsteps@aha.org. This particular email is manned all the time by the team. We try to get back to you within 48 hours, so any questions you have about TeamSTEPPS, be it about the program and some sort of logistical issues, or if you have any questions about TeamSTEPPS content in general, or you're needing help to get to somebody, that's the place you want to go. All right, so I am going to get now to the main content today. We have 2 presenters, Ken Miller and Dr. Edward Lee, both from UCLA, both from our regional training center at UCLA, and I've seen both of them teach, and I'm very impressed with them. Ken is actually coming out to the conference to present this year as well, so you're in quite good hands today. Excited to be able to turn it over to both of them. So I'll be back later for the Q&A. But at this point right now, I'm going to turn it over to Ken and Dr. Lee. Gentlemen?
Good morning from Los Angeles. Good morning from LA, or I guess afternoon for those of you on the east side. Thanks for taking the time to join us this morning. Chris really kind of played up our skills, so hopefully we won't disappoint in the next 40 minutes or so. My name is Edward Lee. As Chris was saying, I'm a hospitalist here at UCLA. I also run our Code Blue Quality Improvement Committee. And next to me is Ken Miller. I'll let him introduce himself briefly.
Hi, I'm Ken Miller. I'm the Simulation Education Program Coordinator for the Department of Nursing here at UCLA. And I also sit on the Code Blue Quality team, as I was a Code Blue team member for about 10 years. And so that's how I've been involved in this project. And I just want to say hi to my nursing orientation program going on right now. I had to leave to do this, and they're all listening, so I just want to say hi to you guys.
So in the next, I guess about 35 to 40 minutes, we're going to try and quickly move through these objectives. So I do want to provide a brief overview of kind of our code team background, composition, and the background of our interprofessional team education here at UCLA. I think that's important because every institution is very different, and some of what we do may or may not be applicable to your specific hospital or institution, and I think giving you a quick overview of what we are like here will help you kind of make that determination. Next, we're going to go through how we came to the process of identifying some of the areas for improvement and how TeamSTEPPS was instrumental in helping us target those areas and improve those areas. So we'll spend the bulk of our time, hopefully, on objectives 2 and 3. And then at the end, we do want to show you some of the data that we've gathered in the last about 2 years, showing the effectiveness of these interventions. So I guess we'll move on from there. So just briefly, the discussion we're having today is primarily at our Ronald Reagan, which is our main university hospital. It's a level 1 trauma center in Westwood, 520 acute beds. We have 6 different ICUs, so a very high percentage of ICU level beds. It is a teaching hospital, as I'm sure you know. We have 76 ACGME accredited programs. It's both at the residency level as well as the fellowship level, and over 1,000 trainees at any given time coming through our program. It is a tertiary and quaternary referral center. We do a high volume of transplant of virtually every organ type. Our Code Blue team composition may or may not be similar to yours. Our primary physicians that respond are our medical ICU resident and intern, as well as the coronary care unit. These are all internal medicine residents, either second and third years for the residents and obviously interns. The anesthesia senior resident is our airway specialist. These are generally what they call CA3 or CA2. Those are third or fourth year residents. We also have a critical care transport RN, which is what Ken did for many years prior to him moving on to these roles. There's a pharmacist that responds, respiratory therapist, usually more than one. We also have an EMT or an escort, and then we have some other services that are notified for other issues such as security, chaplain, our bed control team to look for an ICU bed, et cetera. And then this, I put a star here because the nurses from the affected unit aren't technically part of the Code Blue team per se, but for the last 2 years, Ken and I have really been targeting education and training for the nurses with the rationale that these are generally your first responders. So the vast majority of codes are identified by family members or by nurses or care partners, and the first people to be in the room from any kind of clinical sense will be the nurses from that unit. And so we've been targeting a lot of training to the floor nurses and the ICU nurses to try and build their competencies and their teamwork skills, even though they're not technically part of our Code Blue team.
Historically, from the nursing aspect, nurses who are primary on the floor really kind of feel disjointed from the Code Blue team, quote. When the Code Blue team would show up, the nurses would generally either find other things to do or think that the Code team will take over, but we've really focused on the primary first responders being the most important part of the Code Blue team and bring them into the whole big picture instead of having that separation.
And so when we do our, and we'll go into this a little bit more in a few more slides, but when we do our interprofessional simulation sessions, we actually bring floor nurses into those, even though they're not, again, part of our actual Code Blue team per se.
One of the big programs I've been doing is trying to develop a robust In-Situ Education program where we do 3-minute mock codes. The emphasis of this is really the first 3 minutes of any code, from the time that you establish on responsiveness to getting help. The objectives, we really try to develop the bedside nurses' leadership skills, being able to recognize problems, being able to speak up, being able to develop roles in that first 3 minutes to get people assigned to compression, somebody assigned to the defibrillator, et cetera, and also doing SBAR communication, which we feel in nursing is very valuable when communicating to the physician. And we really emphasize early and high-quality compressions because we really feel that this is the key to survival in the codes. Also, I've been incorporating TeamSTEPPS, these elements, in our nursing orientation program. Currently, we're doing our new graduate program this week, actually, and we incorporate a lot of this through simulation and interactive exercises. So we're really getting out there and hitting the nurses with this information to empower them to really be able to speak up, be able to communicate clearly, and be able to take that leadership role in that first 3 minutes of the code.
So to give you a little bit of background on our interprofessional education, so we began in August of 2012 with a program for advanced simulations for our medicine junior and senior residents. These are more complex cases, more clinically challenging cases. We had an existing curriculum for interns and for those residents transitioning into their second year, because that's when they began carrying the code pager. But these were designed to be much more challenging and really to test the limits of these residents. So that began in August of 2012, and these sessions were scheduled just in time. So they were literally a day or a week prior to these residents being on the rotations where they would carry the code pager. And then over the next few months, in working with Ken, we started bringing nursing involved, and in January of 2013, the sessions truly became interprofessional. As I mentioned earlier, we brought in med-surg nurses, ICU nurses, as well as the critical care transport nurses. And Ken was really instrumental in kind of the logistics of that development. Over the next sort of year, we continued with these sessions, and then in July of 2014, so just the beginning of this last academic year, the Department of Anesthesia committed their residents to these interprofessional sessions. So now at each session we have at least one, sometimes two anesthesia residents who also attend. So we've ramped up significantly since we began. So in the 2013 to 2014 academic year, we had basically one a month. This year we went up to 20, and for next year we're anticipating probably we're going to have 25 sessions. Part of this is because of it's been well received. People generally like these. They feel like they're very valuable. But the other reason is that we're trying to reach more people. And so having a higher number of sessions is really important to getting the training out to enough people. So just some samples of the cases that we do for our interprofessional sessions. These are all simulation-based. We do 3 cases in a half day, so we start around 1 o'clock. We do a brief orientation. We usually finish by about 4:30 for the day. Some of the topics are listed there. You can see it's a broad range. That was intentional. We wanted to hit a wide variety of backgrounds in pathophysiology. Again, these are more advanced cases, so the advanced arrhythmias are not common things that the residents may necessarily see. We also try and hit things that are important for quality metrics. For example, sepsis. You probably are all working on your sepsis compliance with the sepsis bundle, and so we incorporate that as well. And then the last one is one of my favorites. We have a scenario where we actually have 2 patients that decompensate at the same time, and this is really important for crisis resource management and for our residents to better understand what resources are available. The team has to be split in order to deal with both patients simultaneously, and that can be very challenging for the physicians and nurses to kind of understand where they need to go. So that's a really important scenario, not so much for the medical knowledge or decision-making, but much more for the teamwork, the communication, and the resource management. After each case, we do a debriefing. Our instructors are all trained on how to run simulation sessions and how to debrief. Every debriefing starts with a focus on teamwork and communication. I think there's some controversy over whether you should start with that or not in the simulation community, but we've elected to start with that just to make sure that it doesn't get the short end of the stick, that we make sure we hit it and dive into those issues from the very beginning, and then we go to the medical decision-making next.
When we first started debriefing, what was interesting was we separated the teams from nursing and physician, debriefing both kind of specialties, but we really felt that this kind of affected that teamwork and communication. So now it's a all professional debriefing instead of that split. So we found that interesting. Again, in the sim world, there's big debates about that.
Yeah, if you're thinking about using simulation for your interprofessional education, which if you have a sim center, I would definitely recommend, and I know not everybody is fortunate enough to have one, but there's a lot of different ways to run your debriefings, and having the nurses and the RTs and the anesthesia residents and the medicine residents all together also brings its own challenges, because sometimes you end up debriefing on topics that maybe aren't as relevant for some providers as they are for others. So I think there's pros and cons to each way. We kind of experimented with a variety of techniques, and I think in the last 6 months or so have really settled on keeping the debriefing entirely together as opposed to doing part together and splitting or any variation of that. you think about how to improve your Code Blue team performance, I'm sure many of you have probably been to codes or still go to codes, and I'm sure at least some of them you've come away thinking, wow, that was so chaotic, it was so loud, nobody was really on the same page, and I think we've all kind of had those experiences. So when we kind of started these sessions and developed them more and matured in this process, we started thinking a little bit more about what are the specific things that we want to improve as it relates to teamwork and communication. And some of the experiences were just from personal experiences. I did my training here and I've worked here as a hospitalist for several years now, so I've certainly been to my share of codes and had experiences. Ken's probably been to 10 times more than I have. And so some of it was just personal experience. Some of it was talking to the providers that are going to codes currently and just getting their feel of what went well, what didn't go well. Our Quality Improvement Committee reviews codes on a weekly basis, and so sometimes these issues come out of there. We also get an event report from every code that we can review at some point, and nurses will sometimes report issues with leadership or communication or whatever the issue might have been. So from all of these sources, we've been able to kind of glean areas that possibly needed to be targeted for improvement.
And we really want to say that we're trying to make that culture so people will speak up and tell us about problems in the codes, because obviously we're not here at 2 o'clock in the morning. And I've had nurses email me saying this happened, and it's a great, we really feel our culture is changing.
But I would say one of the most valuable sources of information in terms of identifying areas for improvement were actually the IPE sessions themselves. There's something extraordinarily valuable of being the instructor in the control room, watching the providers go through the case and being able to see in real time what the issues are. And it's pretty clear that the same issues we see in the simulation center are the ones happening on the floors and in the ICUs in the hospital. And it helps just being in that controlled setting to be able to think about it, to digest it a little bit more, and to really be able to target those more specifically. So I would encourage everybody here, if you're not already doing this, to really start thinking about putting together some form of IPE sessions, because you will not only see impacts on performance, but you'll also be able to glean a lot of information on areas to improve that maybe you didn't realize were issues at the beginning.
For example, the nurse-physician communication, in the debriefing, what comes out a lot is that the nurse will say, well, I didn't want to bother the physician with that. Or the physician will say, well, we want to be bothered with that. You know, we want you to call us. And it really breaks that hierarchy wall, because they're really able to communicate together in that safe environment and again, working together in collaboration as professionals.
So we've obviously done a lot more than just these 4 things, but we wanted to highlight these things because I think they've been some of our more impactful interventions, and also because they streamline very well with the TeamSTEPPS training components. So pretty quickly, we identified these 4 issues that key information, kind of like Ken was saying, was not effectively shared. And this was between all providers, from nurses to physicians, nurses to each other, physicians to each other, really all around. Second, we noticed that team members would notice a problem but not speak up. And this would come out in the debriefing where, for example, an EKG showed ST elevations, and the team leader reading the EKG read it as ST depressions, and nobody else spoke up that was not the right read, even though other people clearly recognized that those were elevations. So that was another issue. Third, which is I think extremely common, was that orders were not heard or not completed. So the lead physician would call out for medication or a lab test or whatever it was, and it just wouldn't get done. And then the last one is one of our more recent things that we've noticed, was that the teams, particularly halfway through the code or maybe a little bit further, would become very fractured and not on the same page. So in early 2013, as Chris kind of already mentioned, UCLA became one of the TeamSTEPPS training centers, and Ken and I got involved in that from kind of the beginning. And it was extremely helpful for us to gain kind of knowledge of the terminology, of the skills, to better give us a framework to understand what was going on. So the issues that I described just on the previous slide of the problems that we were noticing, or the areas for improvement, TeamSTEPPS really gave us the vocabulary and the terminology to kind of describe them, and also the tools to then more effectively train on them. So, whereas on the first slide of the issues we identified, I kind of used sort of general terms. With TeamSTEPPS knowledge and kind of going through that experience, Ken and I were able to more effectively categorize these as effective communication, where the intervention would then be SBAR, advocacy and assertion, this idea that the culture should be such that any team member should feel comfortable to speak up at any time about an issue, and the interventions for that, the tools were CUS, or the Assertive Statement. The next issue about orders not being performed or not being done, we've addressed by trying to incorporate closed-loop communication. And then the shared mental model, where the team would be very fractured, we've started encouraging teams to use a quick 10-second or 15-second huddle in the middle of codes to kind of get everybody back on the same page. So TeamSTEPPS really helped us in order to kind of better understand or put a framework around these issues to then be able to devise interventions for them.
So first thing we'd like to discuss is SBAR, because we feel SBAR really in a nursing perspective is essential to communicate the issue to the physician or to the responding team. Some examples of this is the code team didn't hear from the primary MD that a patient with a bleed was taking Coumadin. Nobody, it's essential for the nurse who knows the history of that patient to speak up in an SBAR format of saying this, in an SBAR format that patient was on Coumadin and could contribute to the IC bleed. Again, SBAR, that situation background assessment and recommendation. So the situation is the patient's on responsive background. They came in on responsive. He's on anticoagulation. I think he's having more bleed, a bigger bleed. He's on Coumadin, and I recommend that maybe we do a CAT scan or something. The nurse has every right to speak up to that and actually use that SBAR to convey that information to the physician. Oops, sorry. Another case where a primary MD didn't feel comfortable with information relayed by a nurse, leading to a delay in management of a septic patient. Again, these are all problems that we've identified and seen in our simulations. That SBAR, again, is that answer for that clear-cut communication.
I might jump in here, too, and mention that a lot of our nurses, I think, are familiar with SBAR, but most of our physicians actually aren't. Physicians, I think we tend to use a slightly different format of communicating, and so this was really interesting where some of the nurses would already be using the SBAR form of convey information, but the physician didn't really understand what they were getting. And so bringing the MDs on board and at least getting them to understand this format of presenting information helped them to better understand what was being conveyed, even if the nurse was already kind of doing a great job with their presentations.
And that way we're all speaking the same language. Assertive Statement and CUS, again, this is an important TeamSTEPP element to patient safety. And examples of this in our simulations we've seen is like while waiting for norepi drip to be prepared, the anesthesia resident fails to suggest bolusing pressures despite having drugs available. As we all know, sometimes when you prepare a drip, it takes a while, especially if the patient has a PICC line or central line, for that drip to get through if you started off at 5 cc's an hour. Anesthesia sometimes will bolus a little bit of the pressure so we can start getting that patient's blood pressure up. So, again, if the resident fails to do that, somebody can step up and say, listen, I'm concerned and uncomfortable with this low blood pressure. It's not safe. Could anesthesia bolus some a little bit of vasopressin or what we use here. Again, that's being assertive. Team leader reads the EKG as non-STEMI. Another team member clearly sees the EKG shows a STEMI but fails to speak up. There's so many variables when people don't speak up, and I see this a lot in nursing as well, is that you're afraid that you're going to look like you don't know what you're doing. You're afraid to step on people's toes. There's so many variables, but if you understand the tool CUS, it really takes all those variables away, and it gives you a voice, and it gives you that concern and being able to voice your uncomfortable situation, and that it's just not safe for the patient. Failure to speak up when mistakes are delayed in care were noticed by a team member. So we went over the CUS, and the other thing we really are very big on is creating that culture of collaboration and really working together. And it is a cultural thing. I've been a nurse for 32 years, and when I started, it was kind of like, okay, there's this, nobody kind of worked together, especially in codes, and you just let the code team take over and do all that. But we're really working on developing that culture from the time that patient's found to the time of the end of the code, which we feel if we can do that seamlessly as a team, I think we're going to get much better outcomes. Closed loop communication, a couple examples of this. Vitamin K is ordered by the MD but is not clearly communicated to anyone, resulting in the drug not be given to the patient. It's so vital that that person giving the order knows who to give that order to, and that person delivering the drug needs to know to go back to the person giving the order or the leader to close that loop communication. So many times in codes we all see this where a doctor will shout out an order, somebody will do it, but they won't follow through and close loop that communication. One thing we really teach with teamwork is that everybody needs to communicate back to that team leader. That's who they're talking to. That's who they get the orders from, and that's who they close loop communicate with. Another thing, again, arterial blood gas is ordered by the MD, but nobody took responsibility, and then the blood's not sent. I've seen this happen many a times in codes, especially with labs and blood gases. So again, we really emphasize that closed loop communication with the leader, and that the orders are done. Here's an example of the communication and the closed loop communications. Get that real quick.
So the last intervention here is one that's a little bit more recent that we've noticed, is using the Huddle or a shared mental model. So this was really interesting in some of our simulations, actually many of them, particularly in the first case, that the providers would literally physically segregate in the simulation room based on their specialty. So you would have the anesthesia resident or two kind of at the head of the bed managing the airway. The nurses would all be on one side of the room, and the medicine residents would all be on one side of the room, and they would be literally physically siloed inside the room and clearly not communicating with each other, which is kind of humorous to watch, but also obviously not good for communication. And then because of that, and also probably related to that, they were cognitively separated too. So the team managing the airway was not communicating with the medicine residents who were the team, the code leaders, and the nurses weren't communicating with anybody. And so this was really a big problem that we've noticed. And the question came up, well, how do we break this down? How do we break down these barriers rather than just telling people, hey, you got to talk to each other? So one of the clinical examples from one of our simulations that we noticed was the anesthesia resident for an induction for intubation nearly gave succinylcholine because he wasn't aware that the team was considering increased intracranial pressure. So sucks can actually raise your intracranial pressure. This particular patient had intracranial bleed and literally was about to push the medication before they finally overheard that the patient may have increased intracranial pressure and then stopped giving the medication. So we tried a number of different things, just from telling people in the debriefing, hey, you got to communicate better, or just pointing out that they were segregating themselves. I'm not sure how effective that was, just to point it out. Maybe it helped a little bit. But instead of doing that, we've started now encouraging teams to use the huddle. So as things get more disjointed, as teams start to self-segregate or not communicate well, we've encouraged either the team leader or even somebody else to speak up and say, hey, let's just do a quick huddle. Let's get back on the same page to reestablish what's been done so far and where we need to go next. And people were hesitant at first because the thought is, well, we're in a code situation. It's a crisis. This is going to take too much time. But they pretty quickly realized that this can be done in literally 10 or 15 seconds and really helps to get everybody back on the same page. So this is just a brief meeting. Put media in quotes because it's not like you're at a table, to regain situational awareness. Usually it involves the team leader or somebody else giving a quick summary of what's been done. The recorder is a very important role in this to also kind of confirm that, yes, we've given 2 doses of epi, we're 2 minutes away from the next dose or whatever that might be, and then talking about what the next steps are. And just by having this huddle, it really gave people an opportunity to voice their concerns. It kind of tied together a lot of the other tools that we've just mentioned, where nursing could jump in and raise concerns that they had, or anesthesia could jump in and raise concerns that they had, or so on. So this has actually become a very powerful tool for us to use, and it's not something that people are used to doing or even know about. But once they do it once in these simulated scenarios, I think people really understand the value of this tool.
And we're really hoping that they do bring this to their practice and to their clinical setting. Again, like Dr. Lee spoke, people just don't want to take the time to do that because they think it takes too long. But a huddle doesn't mean everybody stops everything and sits around in a circle with their arms crossed. It just means coming together of the minds and taking that 10, 15 seconds to figure out, okay, what's going on here, and everybody having a voice in what's happening.
So we want to talk a little bit about kind of how we implemented it. We don't want to spend too much time on this because every institution is going to be a little bit different, but we do want to talk about this and then briefly mention some of the barriers that we've had to our kind of initiation as well as our expansion. But the first thing I want to mention, as I mentioned before, is that it only works if you do it. And we found it extremely valuable, not just for improving clinical care, but also to get more information on areas that need to be improved that you weren't aware of. So the first thing is to get institutional buy-in, and this is true for any kind of big project. We started on a fairly small scale, so institutional for us meant more the departments that were involved. So someone from nursing, which was Ken, from Department of Medicine, which was myself, and from anesthesia, ultimately, which was our simulation director, Dr. Randy Stedman. Getting their buy-in and their support was really important. And then identifying champions. And I can't emphasize how important this particular piece is. And again, Ken and I have really, I think, been leading this for the most part. But without Ken to kind of lead the nursing component, this would not be possible, and you could say vice versa for any of our main kind of leads in this. You do need to train the trainers. So the people that are going to be doing your simulation instruction, or if you're not going to use simulation, the people that are going to be doing your training for TeamSTEPPS skills, you do need to get them trained. So putting them through a TeamSTEPPS master course, for example, could be very helpful. If there's a simulation instructor course nearby where you are, those can be very helpful as well. But you do need to get them trained on the competencies and the skills. And then you got to motivate providers to participate. And we'll go through that in a little bit more detail in a bit, but that's important as well. And then again, a simulation center is helpful, but it's not required. I think you probably do lose a little bit if you don't use any simulation, but there are sort of lower fidelity simulations that you can use that aren't as expensive as building out your own center. If you do have a sim center, I would encourage you to use that for this type of training. So getting institutional buy-in depends on who you're talking to. I think, and we'll share some of our results here, but there are some patient outcomes data to suggest that this type of training is beneficial. There are financial considerations. The example I would use here is from UC San Diego. They did a very broad intervention for their Code Blue and rapid response, not just TeamSTEPPS or team training, but a very broad intervention. And they saw a huge drop in the number of litigation and lawsuits related to that. And so there was actually a big financial savings at their institution related to kind of their Code Blue training and Code Blue quality improvement. Reportable data is another potential tool you could use. So there are some places that are showing impacts on Code Blue survival to discharge, which would directly impact your mortality numbers for your observed to expected mortality.
And with nursing, too, we like that reportable data from our incident reports of teamwork and collaboration, because it's very important in our aspect of our profession to see if this is working.
And then for those of you that are at training institutions, this last one is actually really useful as well. We needed to get buy-in from our residency program directors in order to have those residents come to these sessions. And it turns out they were actually, at least from the Department of Medicine, we were actually looking for something like this because a lot of our residents were feeling very uncomfortable with being the code leader for the first time, or even when they were more senior residents. So getting their buy-in will be really important as well. And then I've kind of talked about this a little bit, identifying champions from each provider group. This is really important to understand the politics of that particular group. So nursing politics, as I've learned, is very different from physician politics. And the first couple attempts I made at incorporating nursing in some of our quality improvement projects was not very successful. But since I've been able to work with Ken, and Ken's really helped take care of a lot of that, he understands that world so much better than I do. Practical things like understanding schedules, whether they can get time off to come to these sessions or whether they have to be paid for those sessions, just the logistics of it. And then understanding what competencies really need to be addressed, or what is really going to be most relevant for them. You want to make sure that your participants, when they come to these sessions, are getting what they're looking for out of it. Otherwise, they won't come anymore. And so designing your curriculum, your cases, your scenarios, your learning objectives to be specific to those learner groups is really important, and that really requires a champion from that particular group.
And I want to say from a nursing standpoint, the motivation, one thing we did on the nursing aspect is we offer CE credits because the course is, it's a course. So we're able to give them 3 CE credits, which nurses are always looking for. And they also have education hours they can use. But really, the main motivator is they want to be there to practice these skills and to learn really how to act in that emergency situation. So that, to me, the nurses are really more self-motivated, and but the perks do help as well too.
So a little bit about training the trainers here. This is just what we do. All of our instructors that do any simulation instruction have to take a full 2-day instructor course. That's also done through UCLA. Most of our instructors, not all, but most, have participated in the TeamSTEPPS course as well. We have a standard format for our debriefing. So after each scenario, as we mentioned, we do a debriefing. We have a standardized format that all of our instructors use for these sessions to make sure that teamwork and communication gets addressed in a similar way each time. This just helps keep our sessions consistent, because Ken and I can't make it to every single one of these, although Ken almost does. And then we model behaviors. So during the debriefing, instead of just describing SBAR, just describing CUS, we actually demonstrate it. So you might, show the video or describe what happened, and then say, this is how you might address that situation better next time. And we actually demonstrate those skills. I think it helps take some of the novelty away from it, some of the kind of newness away from it. It makes it seem more familiar to people when the instructor actually demonstrates the skill as opposed to just talking about it. And then motivating providers to participate. Ken talked a little bit about CE credits. We have residents at these sessions, so CME credits is not really relevant for us, but if you have staff physicians that are coming, you might consider doing that. You could consider making them mandatory, so for our residents, we actually do. Again, that's something we can do for our residents. May not be relevant to your specific institution. Showing outside data, so, for example, San Diego's improvements or other institutions that have shown improvement with similar types of things, I think can really motivate people to want to do better. If you're having trouble getting broad buy-in, then you might pilot on certain areas, and if you're able to show gains or improvement in those areas, then that can sometimes be a strong motivator to other units or other areas that are more resistant at the beginning. And then peer pressure or word of mouth. So I think this has been helpful. When we first got started, some of the nurses that came through really enjoyed the sessions, kind of talked about it to their colleagues. And pretty quickly, I think Ken got overwhelmed with requests to attend these sessions because we only have a few spots per session. And we had kind of a backlog that we're trying to work through in terms of participation.
I think initially I had 200 applicants for 4 spots. So the word of mouth spreads very, very quickly, which is really the best way to advertise anything.
So some of the barriers that we've encountered, and I don't think these are specific to us. I think these are broadly applicable probably to any intervention you're trying to do, whether it's Code Blue or something else. But getting time, both for the participants as well as the instructors, especially in the last year as we've ramped up the number of sessions, getting the faculty and the nursing instructors to come to these sessions, I think is going to become more and more challenging. We've had to recruit more instructors so that we can spread out the teaching load. Support from the institution, I think, has been a little bit of a barrier, again, as we've gotten very large and tried to do more and more of these sessions. We haven't quite gotten the degree of support that I would necessarily like from our institution, but that's something we're working on as well. If you've noticed, kind of the people that attend these sessions, we're missing respiratory therapy and pharmacy, and we haven't yet identified real champions from those provider groups to help us coordinate with their learners. And then scaling to the entire health system. My vision would be to take this not just to Ronald Reagan UCLA, but our Santa Monica affiliate, and maybe some of our other affiliate hospitals in the area as well. And that's obviously going to be a much larger thing than just 20 sessions a year. So I think these are common barriers anytime you're starting a project and making it larger, but they weren't unexpected, and I think we're gradually working our way through that.
One of the interesting areas we're hitting in nursing is the outpatient area. And we're working with our transport team and the outpatient nurses when a patient does go bad or needs transport to the medical center. How can we better work together as a team to get that patient transported safely?
So I want to share a little bit of our data that we have, and I say this to the end so that people wouldn't log off early. So in 2012, we started collecting teamwork and communication data. So this was before we really started our interprofessional training. And there was a process we went through to try and figure out what was the best way to collect this data. And I think in an ideal world, you would use a validated, studied survey that was being conducted by a trained observer. That would require somebody in-house for most of the day or 24 hours a day who would run to the code and actually just be there to watch the code and go through their 2-page checklist on teamwork and communication. That to us was not practical. If you could do that, I'd love to talk to you and see what your experience would be like, but it just wasn't practical for us. So we incorporated 5 questions into what we call our event reporting system. This is a mandatory report that nurses have to complete anytime there's a cardiac arrest. And so we just incorporate these 5 questions, and the wording and topics were borrowed from some existing validated survey tools, but it's not technically a validated survey. So these are the 5 questions we used. Some of them are graded on a 5-point Likert scale, with 5 being the best and 1 being the worst. Others are yes, no, like was a code leader clearly evident during the code? That's a yes, no question. We felt like that should be 100% of the time, and if it's not, that's a problem. So that was just a yes, no question. So again, some of the limitations, it's not a validated questionnaire. It is completed by the floor nurses who may or may not be trained on how to evaluate teamwork and communication, so there's definitely limitations on this data. And again, it's a subjective rating scale, and that's a limitation for basically any Likert scale. There is an element of bias, so the nurse who generally completes these reports is usually the primary nurse for the patient that arrested, so meaning that they were there for the resuscitation. So there may be a bias where they may want to report things more favorably, but given our limitations, like I mentioned earlier, we thought this was probably the best way that we had at the time to get information on teamwork and communication. So we defined a positive response as either yes to the yes/no questions or a 4 or 5 on the 1 to 5 Likert scales. And the Likert scale has anchors to help the nurses kind of understand what the numbers are for. So this is our data that we have. So again, we began at the beginning of 2012, so you could think of that number as kind of our baseline data. And then in January of 2013, just to remind you, that's when we really started our full interprofessional simulation sessions. And we've continued those obviously through 2014. If you notice, for most of the 5 questions, there was actually a dip between 2012 and 2013, and then a kind of a nice rise back up in 2014. It's interesting, we were talking to some of the TeamSTEPPS leaders, including Chris and Andrea and others, about this kind of phenomenon, and they've noticed this, and maybe they can speak more to it at the end or at a later time, but they've noticed a similar phenomenon with a lot of other projects they've had where the initial scores may actually drop, and the feeling is that it may reflect more of an increased awareness of what good teamwork and communication actually is, and that awareness may arrive faster than actual improvements in performance. And so it was interesting to see that. We had heard that that might happen, and to then see it borne out in our data was kind of interesting. It made me feel more comfortable that the data was somewhat valid. And then it's been nice in 2014 to see the numbers come up. I looked about a month ago at just the first couple months of 2015, and it looks like these numbers are, for the most part, holding steady from their 2014 numbers.
And we're particularly impressed with the leadership scores, because that seems to be the big running problem of who's leading the code. So we're really making a difference with this. I always say, you hear practice makes perfect, but in my eyes, practice makes permanent. And the more you practice these skills, the more likely we're going to see the use of them.
So, well, I think those outcomes are great. I think we all are in this business not to just improve processes, but to hopefully impact patient outcomes. So I did want to share a little bit about our Code Blue survival to discharge numbers. I do want to mention the caveat, this obviously isn't the only quality improvement project we've done at UCLA in the last 2 years. There have been a huge number of QI projects, some of which are directly related to Code Blue and others maybe more indirectly. But if you think about cardiac arrest, it really impacts or is connected to every process you have in the hospital, from patient triage to bed availability to whatever it may be. So I don't think we can say that all of these outcomes are just because of this, but I certainly think this interprofessional training has played a certain role in these improvements. So this is our adult in-hospital cardiac arrest survival to discharge. So going back to 2011, 2012, and really, when I look back historically, our percent survival to discharge stayed pretty much in the low to mid-20s, which was probably just at or just above the national average. The other lines there are derived from AHA statistics. So the median hospital survival rate is about 18%. That has held steady for many years now. The national average survival of in-hospital cardiac arrest has been slowly trending up, but still remains kind of in the low to mid-20s. And you can see in 2013, as we started doing more of these sessions, our survival to discharge numbers took a nice jump up to 32 or 33%, held steady in 2014. I haven't looked at that yet for 2015 numbers, but this was really nice to see. We didn't analyze the pediatric outcomes because our main interventions are really for the adult Code Blue team. The pediatric Code Blue team has their own sort of process that they go through. So just a couple quick summary slides. We at least here think that IPE training is really important for Code Blue team performance, both in terms of teaching skill as well as to understand areas for improvement.
And I really want to emphasize that including that first 3 minutes, because we feel that that's the most crucial time and the crucial personnel in that Code Blue and that outcome. Is trying that unresponsiveness, getting the right help, doing continuous compressions, early defibrillation, that could be done in that first 3 minutes before that code team is able to get there.
So, and I think as we mentioned earlier, the TeamSTEPPS concepts and tools are really effective at teaching teamwork skills. We would encourage you to pick specific skills that you want to impart onto your teams. I think when we first started, we weren't sure exactly what we were going to be doing in terms of interventions, and we spent a lot of time talking about, well, communication teamwork need to improve, but we weren't able to be very specific in terms of what needed to be done. And I think with the TeamSTEPPS skills and language, we were able to do a better job with that by using these specific skills. There are obviously barriers, but they can be overcome. And then the last thing I want to leave you with is that in-hospital cardiac arrest outcomes really can be improved. And I leave this last because I think there is a sense that some institutions, and there probably was here as well, that patients who suffer cardiac arrest in the hospital, there's really not a lot you can do for them. And I think we're seeing growing evidence at different institutions, at different types of institutions as well, not just academic centers, that this really can be changed. This metric really can be moved in a positive direction. I didn't show our neurologically intact survival because I don't have that data quite yet. That's a manual distraction for us. But many other institutions, several other institutions have shown not just improvement in survival, but also improvements in neurologically intact survival.
And I want to say this from a nursing perspective. Until we all, it's physician, nurses, respiratory, all work in a collaborative effort, will we really make a dent in patient safety and improve these outcomes. And that's what IPE really plays a role in TeamSTEPPS, is bringing these two things together to really change our outcomes and have our patients really benefit from this.
So I think with that, we'll turn it back over to Chris.
Thanks, Dr. Lee and Ken. I think you guys did a great job. You really hit a home run being able to show that data and talk about this, so I appreciate it. We've got a lot of questions that have come in throughout the course of this time, so I'm not sure we're going to get to all of them. We probably won't, but I'm trying to, try to get to some that really might hit a lot of what people are thinking. I think one that somebody came in and asked was whether or not both of you being from a teaching institution have an advantage in the respect to people being more receptive to learning. And before you answer, I think this goes to something that we see a lot when we do this, and it's this idea that people feel that with TeamSTEPPS you have to go in and learn right away everything and do everything, and it's overwhelming. And I think that what you've shown here, and correct me if I'm wrong, but you've shown the importance of going at one problem, maybe being a little covert about it, not saying we're doing TeamSTEPPS, but instead saying we're going to use Huddles, CUS, and SBAR to solve a certain problem, and then go from there. So I just wanted you to talk about that a little bit.
One thing I do in nursing orientation is I have a simulation where the physician orders the wrong drug. And the patient, just a brief thing, the patient's on a PCA morphine and the physician orders a breakthrough dose of hydromorphone. And so in orientation, obviously the nurse, this whole Swiss cheese effect takes effect during the simulation, and the objective is for the nurse to be able to use CUS in that situation to avert receiving that wrong order. So a lot of times we do look at those specific tools and apply them to specific problems such as med errors, which CUS is a good tool to use, patient deterioration, and if nobody's responding, CUS is the perfect tool for that. So we do look at that.
I think the point about teaching institutions maybe having an advantage, it's a good one, I think. Certainly at the resident level, my feeling, I don't know if there's any data for this, but my feeling is that they're a little bit more malleable. For example, the 2010 AHA or ACLS guidelines that emphasize compressions over airway, I think caught on almost immediately here because the residents made sense to them. We kind of taught them, and there was no established habit of making sure that the endotracheal tube went in first. So, yeah, I think there is an advantage. That said, many of our codes that happen in the ICUs aren't responded to by the code blue team that I mentioned. They're actually handled by anesthesia intensivists, so these are faculty who have been in practice for potentially many years. The approach to that group, to that cohort of codes and those providers is definitely very different. We don't bring them into the sim lab as learners and do all this. We've tried to actually incorporate them more as instructors and develop their skills by giving them a role as being facilitators and instructors. So I think the approach is very different depending on who you're dealing with, and there may be some advantages to having residents. At the same time, I think there's huge disadvantages because our residents turn over every single year, and it's very hard to then build on competencies that you develop because our medicine residency program is only 3 years long. After that, they're gone. And so we're constantly restarting and rebuilding and going back to square one. So I think there's disadvantages, too, to being at a teaching, but I think the barriers are just different is probably what I would say.
I agree with that, too, in nursing, because there definitely are some barriers, but I agree with that.
So as we're getting close to the end here, I wanted to ask a question that a few people asked. A few people wanted to know what activities were conducted in order to kind of circumvent the traditional physician nursing communication barriers. You know, using the TeamSTEPPS tools, teaching people to use them is one thing, but it's still difficult. It's still kind of at that, advanced level to be able to actually execute something like CUS. So is it the simulations that really helps people become comfortable with that and breaks down those barriers?
I 120% believe it's the simulation because it really breaks down that barrier and people see each other's roles. We've had physicians say, I didn't know a nurse could do that, or I didn't know a nurse did that. A nurse would say, I didn't know you would want to be, informed of this. And in the debriefing, we see that so much. And it's really, again, it's that practice makes permanent. If we keep doing that, it's got to filter over to the floors and to the actual practice areas.
Yeah, I agree. I think it's the simulation. And just another caveat, I don't think you necessarily have to have a high-fidelity simulation. I think you can use low-fidelity mannequins that are much cheaper and more mobile. But I do think that experiential learning is key to this. We do 3 sessions in an afternoon, and we don't start. I think somebody else asked a question, do they get skills before? Some of them may have these competencies before, but we don't specifically do a PowerPoint or anything at the beginning of the session. We just throw them into a simulation. And the reason is because it very quickly highlights these particular issues. And then in the debriefing after that first simulation, we go through the issues that came up and the tools that we suggest they use to try and circumvent them. And by demonstrating them in that first debriefing, I think what we've seen is that by the second case, they start to use it, they try it out. And you can see that they're maybe a little bit nervous. People don't necessarily talk using CUS on a day-to-day basis, so it feels a little bit foreign, but you can see the providers trying it out. And by the third case, you can see that they're much more comfortable already. And this is invariably every session we do. The quality of the teamwork communication between the first case and the last case is like night and day. And it doesn't take weeks and weeks and weeks of training the same team to get to that point. You can really make them comfortable with some of these skills using experiential learning in an afternoon. You're not going to make them experts, but I think you can get them more comfortable with these skills.
And we're even using In-Situ for early sepsis recognition and communication using a standardized patient as an actual patient. And he's unable to give feedback on how he felt as a patient if the nurse was speaking up, which is so valuable because, patient feedback is really essential too.
Well, thank you, gentlemen. We are at the top of the hour, and I think that instead of getting into another question, we should probably call it a day, but we will, for everybody that's joined us, make sure we get your questions answered. We'll post it like a little written Q&A or answer to your questions we haven't talked to on teamstepsportal.org. give us a couple days, of course, to make sure that we have a chance to answer the questions. Also, the recording of this, as well as the script of what has happened, will be up on TeamSTEPPSportal.org as well. If you're interested in sharing it with anybody, or listening again, or reading over what was said. So, I'd like to thank Ken and Dr. Lee right now for coming on and doing a great presentation for us, and thank you all for joining us.
Thank you, guys.
Ladies and gentlemen, thank you for joining us. This conference has now concluded. You may disconnect.